All right. So next thing, ENT and some dental meds we'll be talking about here. You're going to see some return of antibiotics. I know everyone's excited to have more antibiotics. Anywho, so looking at acute otitis media, this is a pretty common thing you guys are going to run into out in clinical practice. Certainly, a lot of kids are going to be coming in complaining of ear pains. You're going to see no shortage of this. Frequently, it's going to be due to viral causes, so obviously no antibiotics are going to be warranted for that. But the most common bugs you're going to be seeing here include things like strep pneumo, H. influenza, Moraxella catarrhalis. Those are your main bacteria you're going to be seeing causing acute otitis media. Certainly, you may see etiologies change over time. H. flu rates will be going down with vaccinations. Certainly you can have some complicated kids who might have like Pseudomonas or something growing, depending on if they have like kind of altered altered anatomy and things like that. But these are the most common ones. As far as the mainstay of therapy goes, really high dose amoxicillin is going to be the thing to go with. You need to shoot for higher doses per day because it is a little bit more difficult to reach kind of adequate concentrations to overcome things like the strep pneumo, especially with the more resistant cases. So this is why we shoot for higher doses. Normally you may say like 45 to 50 milligrams per kilo per day. Here we're shooting for like 80 to 90. So just to give you an idea of the kind of the higher doses we're going for. If you do have someone who has, say, very severe disease, or say they have been given amoxicillin, they fail therapy, they're coming back a few days later, and things are either staying the same or have gotten worse, that's when you want to go ahead and step up your therapy to something like amoxicillin clavulanic acid. Clavulanic acid being what? Yeah, beta-lactamase inhibitor, right? So by doing that, we're expanding our coverage for the amoxicillin, making it a little bit more easily. I can treat things like strep pneumo a little more easily, or kind of expand its coverage. Also, if you have patients who say have had recurrent cases of acute otitis, say they got treated, say a few weeks ago with amoxicillin, and now they're coming back with a new case of acute otitis, that might be another case where they're more likely to have resistant bugs, and so you'd want to go ahead and step up your therapy at that point as well to something like augmentin. If you had someone who really couldn't tolerate amoxicillin for whatever reason, you can always try something like a third-generation cephalosporin like ceftonir, or even azithromycin might be another good option as well. In some cases, we have kids who are very, very sick and they can't really keep anything down, like oral medication. So in some cases, we'll actually do something like ceftriaxone, which again is it's a parenteral drug, which we can actually do. It has a longer half-life, so you can actually get away with doing like 3 intramuscular doses. So it wouldn't be odd for a kid to say come in back to your clinic or your ER for 3 days just to get their ceftriaxone shot if they're really so bad they can't really tolerate oral meds. Looking at rhinosinusitis, you're going to see the same bacteria being the cause here as acute otitis media. You may have some other causative bugs here as well. You may see some Staph aureus, maybe some gram-negative bacilli, but in general, you're going to see the treatment here being relatively similar. Note here that you're going to have a lot of cases of viral sinusitis. You don't want to necessarily throw antibiotics at the patient right off the bat. You really need to make sure you have a high suspicion for bacterial sinusitis. So this is when you do things like wait until they have symptoms for greater than 10 days, and they have this kind of second worsening of symptoms around 5 to 6 days or so. In which case, you want to go ahead and instead of starting with amoxicillin for sinusitis, you want to start with amoxicillin clavulanic. So you really need to go for kind of your little bit bigger guns because of the resistant bugs and kind of the wider range of bacteria which may be causative here. So especially with like beta-lactamase producing H. influenza, like amoxicillin is just not going to cut it. Other options you could do if you had someone who could not tolerate penicillin, you could do something like clindamycin plus cefixime, which is using a cephalosporin plus clindamycin, which is going to have good gram-positive coverage, or you could use something like levofloxacin, which is good broad coverage with that. As far as pharyngitis goes, once again, you see a lot of viruses here, but the main majority of causes of pharyngitis is going to be due to group A beta hemolytic strep. A lot of cases people are carriers of this, may not be having overt disease. And really, when we're treating patients for strep pharyngitis, we're not really so worried about the actual bacterial infection. We're more worried about the secondary complications of it, namely being this acute rheumatic fever. So you're giving antibiotics in order to help prevent this complication because it can lead to things like myocarditis and can lead to congestive heart failure over a long period of time. So you really want to prevent that from occurring in the first place. So one of the things that we've done nowadays is routine practice to help prevent overprescribing of antibiotics is using a rapid strep test. So by doing a point-of-care testing where you can run for a rapid strep test, you can know right off the bat whether or not it's group A beta hemolytic strep, and then you can go ahead and initiate therapy. Some cases you may get a negative result, but you still run a culture, because then you can come back and see if there's something else that was growing you need to be changing up your coverage for. But usual treatment for most cases, you can get away with amoxicillin, just doing 1 time a day. Again, we said that penicillins are time-dependent killers, so they really should be dosed frequently throughout the day. But in this case, since we're really just doing this more as a preventative measure for that acute rheumatic fever, you can get away with using a higher dose just 1 time a day. So it's kind of beneficial, especially if you try to give a kid, a small child medication. The less often you have to do that, probably the better. Another option, say if you had a kid who was having a lot of nausea, vomiting, could not keep any medications down, you could use a parenteral medication like benzathine penicillin. That's that one that comes as a suspension. You want to make sure you're giving it IM only, and that's nice because that's such a long half-life that it will basically just do a 1-time dose, send the kid on their way, and they're good to go, which is nice. Alternatives, if they had a reason they could not tolerate penicillins, would be cephaloxime would have good coverage for this, clindamycin, or azithromycin. Again, always go back to your Sanford guide or whatever your guidelines of choice are, and look at that to make sure because this will change over time. You may see something like amoxicillin going out of vogue at some point, in which case you may switch over to something else as first line. So just be aware that to always check your guidelines and make sure you're using up-to-date info. Okay, moving on, we can talk a little bit about some of our odic antibiotics. And so a lot of the products you're going to see that are available odically will have anti-infectives plus glucocorticoids. So kind of working through 2 different mechanisms, one to inhibit bacterial growth, and then you can also help to decrease a lot of those inflammatory cytokines and deal with a lot of the inflammation and pain that the patient is experiencing. So some good examples of that would be like Ciprodex, which is ciprofloxacin plus dexamethasone. Another option would be neomycin, polymyxin, and hydrocortisone or cortisporin. Those are very common ones. And then you can see some other fluoroquinolones by themselves. And so keep in mind that, you don't really run into as much resistance when you're applying these drugs topically because you're getting such high concentrations that you pretty much eradicate whatever bugs are growing there. So you can use these for otitis media, you can use this for otitis externa. Some things to note when you're trying to select different drugs for different patients. One, if they're going to have an allergy to anything, it's typically neomycin, which can cause kind of a contact dermatitis, so that can occur, so be aware of that. And then for anyone who has a ruptured tympanic membrane or has tubes in place, you do not want to use polymyxin. We mentioned those before as having some pretty significant neurotoxicity and things, and so this can actually cause ototoxicity as well when applying it. So again, if they have a non-intact tympanic membrane, no polymyxin for them. Very frequent thing that a lot of people want to prescribe because it's so easy to do is just ciprofloxacin plus dexamethasone, but it's a very expensive product. Some patients' insurances might not actually cover that. So in some cases, what we'll do as an alternative is actually prescribe 2 different drops. We can use ofloxacin, the odic product, and then you can actually give the dexamethasone ophthalmic. So you can use, say dexamethasone ophthalmic, but you're actually going to be using it by the ear. Okay, so you can use eye products in the ear. That's okay. But you don't want to use ear products in the eye, right? Because they're not really formulated for it. The tonicity and pH might be off. It can be very irritating to the eyes. So eyes to ear is okay. Okay, as far as antifungals go, I only have a couple of these, one of which being ketoconazole. This is, again, is antifungal. This is actually working by inhibiting fungal cell wall permeability, prevents further propagation of their cell wall actually by inhibiting CYP450. So funguses have their own varieties of CYP450, and in this case it's responsible for generating that cell wall. And so ketoconazole and all the other azole antifungals can help to prevent that from being formed. This one, you do want to be aware that they can cause some QT prolongation. So again, by itself may not be a big deal, but if you have a patient who, say, has a congenital prolonged QT or had other medications on board that could prolong it, that could be a problem. And then also because it's inhibiting CYP450 for the fungus, it'd be nice if it was really selective just for that, but can also inhibit CYP450 enzymes in people as well. So if you're using this systemically, you can actually end up getting some CYP enzyme interactions, namely through 3A4. So again, anything that's metabolized by CYP3A4 can be affected by this. So things like, your some of your HMG-CoA reductase inhibitors, like your statins, for hyperlipidemia. Certain heart medications, antiepileptics, things like that can all be affected by this. So anytime you're applying it systemically, this is a possibility here. So here's some other example medications you probably would not want to combine this with due to that CYP interaction. So things like amlodipine, nifedipine, you're going to become more familiar with these when we get to the cardio section. But just be aware to check your drug interactions before prescribing. Make sure you kind of avoid any of these big interactions. Nystatin's another good one. This is a good antifungal because it's non-absorbable, so you really don't see any systemic toxicity for this one. The main place you're going to see Nystatin being used is either topically as kind of a powder for certain fungal, topical infections, but you can also see this being used for oral thrush. And so this is a good agent that you would give for especially immunocompromised patients, so like cancer patients who might be more prone to fungal infections. You can give Nystatin in order to help prevent the fungus from actually establishing itself, or to treat an already ongoing thrush infection. This one works a little bit differently than ketoconazole does because it actually binds to sterols in the fungal membrane, and then by that way it actually will inhibit cell wall permeability, or at least open it up to allow the cell contents to flow out. So a different way to inhibit that cell membrane. So that means that when you, just like vancomycin isn't really absorbed in the GI tract, Nystatin isn't either. So a lot of times when you're looking at instructions for Nystatin, you may see like swish and spit or swish and swallow. It doesn't really matter because even if you swallow it, you don't really have any absorption unless you don't really have any systemic toxicities from it, right? So you saw ketoconazole, even though it could probably also treat a candidal infection, the issue with it is the drug interactions and other side effects that can make Nystatin something much more preferable if you can get away with it. Right, so ketoconazole might be better for more systemic infections, more widespread. But if you just had like just a thrush infection in the back of the throat, Nystatin's a really good drug to do that. All right, I will talk about a couple of antivirals here. I don't really talk about these elsewhere, so this is a good spot to kind of mention the majority of them. So herpes virus, there's a couple different varieties. Certainly type 1, you're going to see more kind of in the ENT kind of realm. Type 2 is what's responsible for your genital herpes. You can also have things like varicella zoster, which is responsible for chickenpox and your shingles. And then one that's more responsible for infection in immunocompromised patients are going to be your cytomegalovirus. So you see this in AIDS patients and cancer patients, people who do not have a competent immune system. This can lead to things like esophagitis, retinitis, colitis. You guys remember that that ocular insert that we saw, the ganciclovir ocular insert? That actually is to deal with cytomegalovirus retinitis. It can happen in certain patients. So you guys should be able to draw these for the next test. Just kidding, don't do that. Just kidding. Yeah, everyone's like, oh gosh, he's probably not kidding. So the point of putting the structures on here is to kind of illustrate the differences between the drugs. And so if you look at something like valacyclovir and looking at acyclovir, you can see the structures are actually kind of similar. The thing to note is that the medications on the right are prodrugs, which means that they are drugs that are not active in their current form, but when they get metabolized in the liver, they get converted over to their actual active compound. So valacyclovir gets converted over into acyclovir. So why would we do that? Why would we give valacyclovir instead of acyclovir? Any ideas?
Bypass the first pass.
Okay, so you're on the right track. You're not bypassing the first pass because you're actually undergoing it as you get absorbed, but you have a larger proportion of drug making it through, so you actually do increase your bioavailability. So that's one of the big reasons why we give these prodrugs, is to increase the bioavailability of them. So valacyclovir and acyclovir will be the first two we'll talk about. So Valtrex and then Zovirax. These are probably the more common ones you'll run into in clinical practice. So these are going to be working basically by inhibiting viral DNA replication. So these are guanine analogs that end up getting incorporated into the DNA, but they don't have that sugar backbone, so they can't really keep elongating the DNA further, and that's going to end up triggering that cell death, or the viral death. You see acyclovir and valacyclovir mainly being used for things like herpes simplex, varicella zoster if you have a shingles outbreak, or certainly if you were having, say, like a herpes stomatitis, something like that. In some more severe cases, usually something like oral acyclovir can be utilized for that. And so if you look at the bioavailability between these two, you can see the pretty stark difference here. Maybe only 22% for acyclovir, whereas like 70% for valacyclovir. Even though it's a kind of more expensive product, you get more bang for your buck out of it, you get better absorption, so it may lead to better efficacy there. You'll see that the adverse effects of all these antivirals are pretty similar across the board, so kind of keep these in mind as we move forward. But essentially, big things you're going to be seeing is going to be nephrotoxicity. So you worry about some of the drug crystallizing out in the renal tubule, which can cause an acute interstitial nephritis. So that can be bad. It can lead to some acute kidney injury. You also are going to be looking at bone marrow suppression as a possibility. You'll see that some are going to be worse than that than others. So, these are probably the best tolerated ones, and as we move forward, we're going to see worsened side effects. And then also CNS effects. So certainly patients who have seizures might be more at risk for developing this. If they already have altered mentations, say due to dementia, this can get worse in some of these patients, especially elderly patients. This can be a problem. So when you're thinking antivirals, think bone marrow suppression, kidney issues, and then CNS issues. Those are the three big ones. So again, make sure they're taking lots of water because they want to maintain hydration in order to help prevent the drug crystallizing out in the kidneys. Yes?
Can you repeat those last three you just said, the bone marrow suppression and the other two that were the big ones?
Yeah, so bone marrow suppression, kidney injury,
Okay.
again, that's due to that precipitation, and then CNS toxicity. That's another possibility there. Then we'll have pencyclovir and famciclovir. Again, famciclovir being the prodrug that gets cleaved into pencyclovir. Very similar mechanism to acyclovir, so no big differences there. Again, used for very similar indications as well. The toxicity is worse with this, so you end up seeing these used less frequently, or in cases of resistant viruses. So in some cases, you'll have patients who have been on antiviral therapy for a long period of time. They develop these resistant strains, and thus you have to kind of step up your therapy in order to use these more kind of toxic products, but ones that are going to be more efficacious against those resistant strains. So you can look to see something like pencyclovir only has about 5% bioavailability, so it's only given IV because you don't really get enough absorption orally. Versus famciclovir, it's a prodrug, get much better absorption. You can give that via the GI tract. Then you have ganciclovir and valganciclovir. Again, valganciclovir again cleaved over into ganciclovir. So these you'll see being used more for cytomegalovirus typically. So either in transplant patients who are on a lot of immunosuppressants, cancer patients, things like that. Obviously here the differences in bioavailability are pretty obvious. And then looking at your bone marrow suppression, like your thrombocytopenia that can occur here, can be more frequent. CNS toxicity. And then in a lot of cases, you have patients stop therapy just due to the side effects. So again, these are not very well tolerated drugs, and so should really be reserved more for resistant infections.
So you'd also, because of the thrombocytopenia, you'd also be careful with people like on blood thinners and stuff?
Yeah, absolutely. So yeah, if you were worried about someone who had a bleeding diathesis, or someone who's on anticoagulants, certainly that could be an issue. So you'd want to be monitoring their CBCs, before therapy starts, and then as they go forward, to make sure that's not going to be an issue. Yeah, good point. Phosgornet is going to be another one you don't see too frequently, but certainly for more resistant viral strains. This one is more specifically inhibiting viral DNA polymerase directly. This one is administered IV only, so there's no kind of prodrug version of it that's available, and it is renally eliminated, so you do need to dose adjust for that. Not only that, but it's going to be nephrotoxic and chelate a lot of cations. So it can lead to things like hypocalcemia, hypomagnesemia, hypokalemia, all those good electrolytes we like to keep in our system can end up getting chelated by that. You guys know what chelate means? Yeah, so it's kind of like if you were to chelate lead out of the body or something, you're giving a molecule that's going to grab it and make it more soluble so it can be eliminated in the kidneys, right? So you'll see some drugs that are therapeutically chelators that will chelate things like iron or lead, but in this case, this is doing kind of a bad chelation for us. Again, this is going to be more reserved for the really resistant bugs or more severe ones like cytomegalovirus. You can see here the adverse effects are going to be pretty similar to what we saw previously. Okay, so moving on into some anti-inflammatory drugs we can use for ENT complaints. First one's going to be our salicylate, so acetylsalicylic acid, otherwise known as aspirin. If you ever guys want to know where the term ASA comes from, that's where it comes from. So acetylsalicylic acid is ASA. So this is a very old drug, has good oral absorption, gets hepatically conjugated and then excreted through the kidneys. What this is going to do, and the kind of thing that differentiates this drug from some of our non-steroidal anti-inflammatory drugs, is that this is an irreversible inhibitor of cyclooxygenase. We've talked about cyclooxygenase before. It's also non-selective, so it'll be affecting COX-1, 2, and 3 pretty much equally. No real selectivity there. The fact that this is an irreversible inhibitor, especially on the platelets, is important because this is why we use it for heart protection, right? Because we want to prevent platelet aggregation, blocking off our coronary vessels, leading to myocardial ischemia. So this is why we use it for that. We'll talk more about this in cardio section, but just be aware that that's one of the big reasons why we can use it for prevention of MI and whatnot. So you can see that the doses of aspirin are going to range pretty widely. So if you're using it just as an antiplatelet effect, just as a cardioprotectant, you're going to be using pretty small doses. So say like 81 milligrams, which would be like your baby dose of aspirin, is enough if you take it every day to completely inhibit all of your platelets. As you get to bigger doses, you're going to see more antipyretic and analgesic effect. So your 650 to a gram dose will be where you see this. And then anytime you get the doses higher, this is when you start to see more inflammatory action, which is good, but you're more likely to see toxicity. So sometimes you'll see patients who are, say, like rheumatologic conditions that need anti-inflammatories on board. Sometimes high-dose aspirin will be used, but in a lot of cases, you're just going to get more toxicity. So things like tinnitus, where they complain that they are having ringing in the ears or they can't hear, things sound very muffled, and then they can get all the way through these different metabolic changes like metabolic respiratory alkalosis, metabolic acidosis, all kinds of bad stuff. Get to tox, we'll talk more about that, but just be aware that kind of the dose range you're staying in is going to usually be a gram or less. Now, has anyone heard of like Goodies powders or BC powders? What are those? Yeah, so basically it contains aspirin, but one of the things to know, and I think if you're from up north, I've kind of encountered that a lot of people have never heard of these. It seems to be more like a southern thing for whatever reason. But essentially they're like these little sachets, these little papers that contain powdered aspirin. And so a lot of people, because they're so ubiquitous and they can kind of get them from anywhere, they may not realize that they're actually aspirin and they're actually a drug. So in a lot of cases when you're asking patients, what do you take every day and what kind of medications are you on, they may not think that BC powders, like Goodies powders, an actual medication, right? So sometimes it's good to ask about that. There's lots of patients who have become very toxic because they would take these aspirin packets every single time they had a headache or they had chest pain, and they would keep kind of overdosing themselves chronically, which can lead to some pretty bad toxicity. So just be aware of that. So certainly some contraindications. Because this inhibits your platelets, you're more likely to have bruising and bleeding. So if you already had a bleeding disorder, you probably want to avoid this. Certainly avoid in pregnancy for the most part. You'll see that anything that's inhibiting cyclooxygenase, especially in the second and third trimester, probably should avoid for the most part. And then the other big thing you want to be worried about is that for children who have fever, especially associated with the viral disease, namely like chickenpox or influenza, you do have increased risk of Ray's syndrome when you give them aspirin. So this is why aspirin is generally going to be not recommended for kids less than 16. Okay. So you may ask yourself, what is Ray's syndrome? Have you guys heard of this before? Exactly. So Ray's syndrome is this fatty liver encephalopathy, and so it used to be a much bigger killer of children until there's a lot of movements out there to try to make it more well known, to make sure people are aware of the risk of this. So basically, what they saw that if a kid does not get treated in time, they can have upwards of a 50% mortality. And the thing is that you have a kid who's having influenza, they are having a fever, they're throwing up, and then all of a sudden they start to have this Ray's syndrome pop up. It looks very similar to that viral illness they're already having. So they're having vomiting, they're having some lethargy, things like that. It may not seem all that odd, but really what's happening is this kind of progressive CNS damage and this fatty encephalopathy that's occurring. It's fatty hepatitis that ends up developing, and so it can really has the potential to go unnoticed for some period of time. So that's why it's always really, really important that if they have a history of viral illness or any kind of sickness previously, really try to avoid the aspirin. Now, certainly there are some cases where you do want to give aspirin to young children, especially Kawasaki's disease, which we're not going to get into here, but that would be an indication where you do want to give them aspirin. It's actually one of the mainstays of therapy for that. But in general, probably just avoid it just to be safe. You can see it kind of develop over these different stages. So, initially they have the rash on the hands and the feet, they're vomiting, have high fever, again, it looks very much like a viral illness, but then they just are not acting right. They're getting very, very lethargic, encephalitis is starting to develop, and then they just kind of get progressively worse from the CNS standpoint. Anyone know why I put Pepto Bismol on here?
Because it makes your mouth black.
That could make your mouth black, but does anyone know why it has anything to do with Ray's syndrome? What is Pepto Bismol? It's bismuth, but there's another part to that. bismuth subsalicylate. So that salicylate is actually in there. So it's important to remember that Pepto Bismol does have a salicylate product and could lead to Ray's syndrome. That's the one thing that a lot of people don't actually realize, is that salicylates are contained in that. You're absolutely right, though. It does change your stool and your mouth potentially black, but that's the big thing we're going to focus on here. And I'm pretty sure my mom gave me a ton of Pepto Bismol as a kid, but fortunately I survived. So maybe not unfortunately, who knows. But anywho, some other anti-inflammatories that are frequently prescribed for ENT complaints would be Motrin or Ibuprofen. Again, this is our non-steroidal anti-inflammatory drug. I'm sure most of you guys have taken it at some point in your lives. It's an anti-inflammatory, analgesic, and antipyretic. And so it's non-selective, so it's going to work in COX-1 and 2 pretty much non-selectively, and it's going to be a reversible inhibitor. So you don't see as much bleeding risk with reversible inhibitors like these NSAIDs versus something like aspirin. So usually you're only going to have kind of more bruising, bleeding risk when the drug is actually on board. As soon as you metabolize it, the risk is kind of gone because of that reversible action. So again, this is going to be more for kind of that inducible cyclooxygenase 2. So if you have a sprain, if you have an area of inflammation, something like that, this is going to be the better drug for that kind of thing, because it's working on that inducible type of cyclooxygenase. The big risk we worry about is because it affects COX-1 as well, is that's really important, because that's that constitutive cyclooxygenase is really important for protecting the stomach. Kind of helps with that mucosal barrier. That helps prevent erosion with the stomach acids. Can also lead to acute kidney injury, especially in patients who already have kind of poor kidneys to begin with, and can worsen hypertension. So we'll touch back on NSAIDs kind of periodically through the class, but just be aware that they interact with a lot of different disease states. Some other interactions you can see, any kind of antihypertensive, they're going to be kind of antagonistic too. So like your ACE inhibitors, which we'll talk about in a couple weeks, can worsen things like accumulation of lithium, which is lithium you'll see something used for your bipolar patients. Can worsen secretion of things like methotrexate. That can be really problematic, especially since methotrexate is a cancer drug that can lead to really bad bone marrow suppression and things like that. So just be aware of that. In some patients, they may actually have an allergy to NSAIDs where it actually induces their asthma. I'm not going to get too into the mechanism of that until we get kind of more to the asthma section, but just be aware that some patients will have a contraindication to this if they have a history of asthma that with a reaction to NSAIDs. Yeah, and then anyone else who's got like a previous history of like duodenal ulcers, stomach ulcers, anything like that, they should be aware of avoiding NSAIDs. Next, we have Tylenol or acetaminophen. If anyone curious where the name Tylenol actually comes from, if you want to impress your friends with your pharmaceutical knowledge, the chemical name for Tylenol is para-acetylaminophenol. And so you see that TYL and the ENOL in the name, that's where it comes from. It's also where the APAP comes from, that basically kind of rearrange that, amino para-acetylphenol. That's where the APAP comes from, so there you go. So this one is going to be working more centrally by inhibiting cyclooxygenase 3. COX-3 is more kind of centrally located in the CNS, and so that's why you don't really would recommend Tylenol for like a sprain or something like that, because it's not really going to be affecting the inflammation kind of work out in the periphery. This is going to work more for kind of centrally mediated pain, as an analgesic, but it also is a very good antipyretic as well, so it can deal with fever as well. Notice here, what's the big organ toxicity we worry about with too much Tylenol on board? Yeah, liver's a big thing that takes a hit here. So usually we recommend not to exceed 4,000 milligrams in a day. Keep in mind though that a lot of the over-the-counter recommendations actually even drop that lower. I think like 3,250 I think is what they really recommend, mainly because even if you took 4 grams a day every single day, and some people take this stuff religiously, that can even lead to some hepatic injury over time, especially if they have kind of a pre-existing hepatic injury already. So if you have like cirrhosis or something, you'd be more prone to toxicity from this. Certainly alcoholics who have kind of chronic like hepatitis or things like that can be more prone to having toxicity from Tylenol, so be aware of that. And no big contraindications. It's kind of preferred in pregnancy for pain and things. But if you have an allergy, obviously you wouldn't want to take it at that point. Okay, next we'll talk about our antihistamines. So we know histamine is really important for mediating a lot of immune reactions, especially if you have allergies and you have someone, like I said, popped a cat in that office and I walked into it. I would certainly have a lot of histamine being released all of a sudden. That's responsible for that kind of triple response. So you see that redness, which is due to a lot of vasodilation of the vessels. You're going to see that edema that can happen. So when those vessels dilate, they get more leaky. So more fluid's going to leak out of it, causing edema. And then you have that redness that can occur as well. So that's really due to some reflex vasodilation as well, right? So that's that triple response you see. Lots of different histamine receptors located throughout the body. The main ones we're going to focus on for kind of ENT concerns are going to be our H1 receptors antagonists. You can see here that they're located on the heart. You can see, in the bronchial smooth muscle, they're going to be present. Typically, when these are being activated, you're going to be seeing mostly vasodilation that's going to be happening here. But we're also going to see that these are going to be important for certain CNS effects when we were looking at some of our antihistamines. H2 receptors are going to be more important in the gastric tract. So when we talk about GI drugs, we'll talk about our H2 blockers there. So again, H1 receptors, they're really working to increase that post-capillary permeability. They're increasing vasodilation. They can also be related to increase in mucus secretions. That's where you get a lot of the kind of runny nose, and you get a lot of kind of mucus being formed there. Have increased smooth muscle tone, and then also bronchoconstriction can happen here as well. So that can be a problem for your asthmatic patients and whatnot. We see H2 receptors more in the GI tract. They help to stimulate gastric acid secretion, but they can also be used in some of the kind of the long-term complications of some allergic reactions. So sometimes like in things like anaphylaxis, you might actually see H2 blockers being given here as well, but we'll talk more about that when we get to the pulmonology section. Yes? Yeah, so like ranitidine, Pepsid might be another one, famotidine. Yeah, so we'll talk about that when we get to the anaphylaxis section in the pulmonology stuff. But essentially, when you're having, histamine is really non-selective when it interacts with those receptors. So just because you're having an allergic reaction, it doesn't say, hey, let me go affect just the airway H1 receptors. It's going to affect your H2 receptors as well. So you worry about having a lot of GI side effects from that. And so that's where some of the H2 blockers can have some use, again, to help prevent some of the nausea, vomiting, things like that. Yep, so good observation there. There's also some H3 receptors, but we're not really going to get into that. Not many drugs will actually affect this, but it's thought to maybe have some interactions with sleep and promoting wakefulness, so you may see some drugs eventually one day kind of targeting these H3 receptors. Okay, so if we have an H1 receptor antagonist, some of the things we're going to be seeing from their actions, they're going to be blocking smooth muscle contraction. So that's going to be both in the GI tract and also in the bronchial smooth muscle. So that's going to be kind of really important for allergic reactions. It's going to help block rapid vasodilation. It's also going to help to decrease a lot of the secretion and edema that we're going to be seeing happening from this, a lot of itching as well. So if you were having an allergic reaction where you're having a bronchoconstriction due to that, then yeah, an antihistamine would be able to help with some of that, right? Because all of that stuff is still mediated through the same pathways. Yeah. You'll see a lot of CNS effects that are associated with these H1 receptor antagonists as well. Some of it is due to H1 receptors. Some of it is going to be due to muscarinic receptors. Have you guys talked about muscarinic receptors at all? A little.
Oh, with you.
Just with me, okay. So muscarinic receptors, when you block those in the CNS, you typically are going to see, this is where a lot of the sedation comes from with a lot of these H1 blockers, is due to muscarinic receptor antagonism. There's a whole mnemonic that goes along with blocking those receptors, which I won't get into right now. We'll talk about as we kind of come up to it. But certainly you can have synergistic effects if you had other CNS depressants on board. So if I were to take, say, a bunch of Benadryl and then drink a bunch of alcohol, you're going to see synergistic effects on the CNS depressant effects. It can be marketed as an OTC sleep aid, so doxylamine is a very frequent one, so Unisom would be one you might see out there. And then even at higher doses, when you start to kind of increase the doses, you can start to see more restlessness and excitation. You may see this more in children, so especially, this is why I'm still scared to give my 4-month-old Benadryl ever, but I'm worried that if I give it to her, some kids will have a paradoxical reaction where they will actually get super hyper ramped up, bouncing off the walls crazy, instead of getting like nice and sleepy like you would hope they would, which is why I've not tried it yet. But certainly as you ramp up your dose, you kind of overcome that sleepiness and that lethargy, and you're going to get more excitation. Potentially you can see hallucinations, euphoria, seizures. So this is why why over-the-counter H1 receptor antagonists are very common agents for abuse, because a lot of teenagers have way too much time, easy access to the stuff, and not much wisdom to not abuse it. So if you ever hear of someone doing a bunch of triple C, that stands for quercetin cough and cold, which is a very common over-the-counter cough and cold medicine that is containing some of these antihistamines. So just be aware of that. Kids do lots of dumb stuff. Sorry? Only if it has pseudoephedrine in it. Yeah, not for quercetin cough and cold. So anyway, yeah. And none of you guys would ever have done that, right? That'd be a bad idea. Don't do that. So the thing you will see with our H1 receptor antagonists is that the second generation agents do not cause much sedation. So that's a benefit of them being a second generation, and that's because they don't enter the CNS. So because they can't cross the blood-brain barrier due to some physiochemical properties they have, like having like a positive charge on them all the time, that prevents them from going to the CNS, and thus you prevent a lot of that CNS depression from occurring. So some other kind of non-specific effects we can see with the first generation agents only, because again they're affecting the CNS. You'll have some antiemetic action, some antimuscarinic action. So again, when you're blocking muscarinic receptors, you're also decreasing a lot of mucus secretions. So you can see this can be useful, especially if you're having a lot of rhinitis and a lot of nasal dripping due to your allergies, that your H1 blockers could help to blunt that. And then maybe even some anti-serotonergic effects, which we won't really talk too much about here. But mainly the antiemetic and muscarinic actions are the useful clinical effects. As far as the antiemetic actions go, so not only is it due to the antimuscarinic actions, but also due to some actions on that chemoreceptor trigger zone. Again, that's really responsible for a lot of nausea, vomiting effects. And so probably one of the most common ones that you'll see being used for nausea and vomiting, has antihistaminic actions and antimuscarinic actions, would be promethazine or Phenergan. This is very, very strong antimuscarinic actions, and so it's really, really good for dealing with nausea and vomiting. So especially if your other agents have failed or they can't take other agents, this is a really good drug to use for that. You guys ever heard of Scissorp, purple drink? It's actually promethazine and codeine combination product. But yeah, so Phenergan, because it has such strong antimuscarinic actions, it'll really knock you down pretty good too. Very, very heavy CNS depressant effects. I remember one time I was having a really, really bad stomach bug, and I was just throwing up like crazy. My aunt was like, "Here, try one of these," and I said, "Okay," and I was out for 12 hours after taking a Phenergan. So very, very strong antimuscarinic actions there. So our indications for these guys are going to be for allergic reactions. So it could be anywhere from just allergic rhinitis all the way up through drug hypersensitivity. We can see if you're having some motion sickness, nausea or vestibular disturbances, so certainly vertigo, seasickness, things like that. These are all going to be good drugs for those. Over-the-counter sleep remedies, and again, like we mentioned, anaphylaxis. They're good adjuvant drugs to have on board. Adverse effects we kind of already mentioned, so sedation could be a big one. Potentially some GI disturbances. You don't really see too many of those. And then other actions from the muscarinic antagonism is going to be due to things like dry mouth, urinary retention due to kind of decreasing secretions. You can also see some effects on the eyes where you have like blurred vision. So the big mnemonic we use for antimuscarinic actions, might as well just mention it now just so you guys have it kind of in the back pocket. So blind as a bat. Right, so you have kind of decreased, you end up causing mydriasis and blurred vision. You're dry as a bone because you're decreasing secretions are coming out. You are red as a beet. You're having some vasodilation that's occurring from there. You're mad as a hatter. That's due to some of the CNS effects like the lethargy and the excitation. And then hot as a match. So you can be hyperthermic due to antimuscarinic actions. So all these drugs, especially in overdose, could all cause these effects to occur. Okay, so the drugs we'll be looking at here. Notice that your first generation agents are segregated from your second generation. Notice that the second generation agents will not be really having a whole lot of antimuscarinic effects. So these agents, like your cetirizines, your fexofenadines, and your loratadines, are not really good for antiemetic actions. They're also not really good to dry you out like you would see with your first generation agents, right? That's all based on the fact that it cannot get into the CNS. So it'll be one of the big differentiators between those two. And you can kind of see that if you look at the difference in the sedative effects, the antiemetic effects, and the anticholinergic effects. So really, you will see your second generation agents are really good for decreasing. They're really good like prophylactic agents, especially if you can take them before you know you're going to be exposed to an allergen. That can be good to help prevent them from occurring in the first place. But if you're having like a really bad acute allergic reaction, like your first generation agents are going to be the one to go to because they're going to be able to work on a lot the CNS effects as well. And then we also have an intranasal agent like Nystatin, which will be working more locally within the nose itself. Okay, so I think I'm going to stop here for now. We will figure out the test stuff, and then I'll look through it and make sure there's no givebacks or there are miskeyed answers. So I'll go look through that tonight, and then we'll continue next week. All right, thanks.